So Common Ground is a web-based application designed by and for those of us with psychiatric disabilities, and Common Ground aims to help people prepare to participate in their recovery and in making shared decisions with their psychiatrists and their treatment teams about the next steps in their treatment. But I'd like to begin at the beginning of how I came to develop this web application. My story began in the 1970s when I was a 17-year-old senior in high school, and at the midterm break in high school, I had a psychotic break. And I was told that I had a disease called schizophrenia. And I was told that no one gets well if they have a diagnosis of schizophrenia. I was told that I would need to take powerful and high-dose antipsychotic medications for the rest of my life. I was told to quit school. I was told I had a disease that was like diabetes, and just like a diabetic had to take medications for the rest of their lives, I too would have to use antipsychotic medications for the rest of my life. I was told to go on a government check, to live below the poverty level, and to avoid stress all at the same time. What they didn't understand, of course, is that boredom is profoundly stressful, and retiring from life at the ripe old age of 17 was also very stressful. And in those early years, I believed my doctors. I thought they must be right. They went to Harvard Medical School. They were bright enough people. And I had never heard of anybody getting well. And so I followed my doctor's advice. And I took high-dose antipsychotic medications, and I returned to the hospital every now and again for treatment. And I was in ambulatory outpatient psychopharmacology care, went home to my parents' house, and my life consisted of sitting in my family's living room, smoking cigarettes, which was a habit I had picked up while in inpatient units, and simply sitting there smoking cigarettes. I would get up at 8 o'clock in the morning, smoke some cigarettes, have breakfast, sit in a chair all morning, eat lunch, take a nap all afternoon, get up around 3:30, sit in a chair, smoke cigarettes. People would come by the house. I'd have nothing to do with them. Now, what's really interesting about this is that I was treatment compliant at this time. I was using the medications as prescribed. And indeed, the medications did muffle some of the symptoms that I had been having, but I was on so much medication that all I could do was to sit and smoke cigarettes, and I call this the Coke and Smoke syndrome, where you just sort of sit there and vegetate. I was so sedated and so emotionally numb as part of the medication effect that not only was my disorganized thinking gone, but my ability to think at all had pretty much gone as well. And although my auditory hallucinations were not bothering me anymore, the truth was that nothing bothered me anymore because I couldn't feel anything anymore on these medications. I was somnolent. I slept a lot. I had no interest. I had not returned to school. I stopped seeing friends, and I sat on a couch smoking these cigarettes. And in effect, at that point, I felt disabled not by the illness, but by the treatment. In fact, I was in chemical hibernation. But what's fascinating about this is that by all measures, I was a treatment success. I was a treatment success. I lost years of my life in this netherworld, and even though I was treatment compliant and I was maintained in the community, I was not recovering in any sense of the word. As a treatment success, my psychiatrist viewed me as a treatment success because my treatment resulted in reduced healthcare costs. I wasn't using as much high-end services anymore. They had reduced my readmission rates to 0. And they had increased my community tenure. All of the outcomes that matter, all of the outcomes that we measure. I was a treatment success. This is what my life was about at that time. I was living out my life within the landscape of the human services. And I call that a life where the only people who are with you are people who are paid to be with you. It's a life in handy captivity. And that's how I spent quite a bit of time. The patient, the person, me, was now disabled, not by a psychiatric disorder, but by the treatment itself. Now, I wish I could tell you that the reason this occurred is because I had a dumb, unenlightened psychiatrist, but it's not the case. He was among the best and the brightest. He was a resident at Harvard Medical School. And yet when we sat down together in a psychopharmacology consult in the ambulatory care clinic at the Beth Israel Hospital in Boston, a Harvard Medical School teaching psychiatric unit, I would say, I feel sedated. But my psychiatrist's perspective is, but you're not psychotic. And I would say, I'm still hearing distressing voices. But his perspective was, you're not shouting at your voices anymore and getting the neighbors upset. And I would say, I can't think clearly on this medicine. And he would say, but you're not thought disordered. And I would say, I feel like the meds are controlling me. And he would say, no, you're more in control. And I would say, I'm not myself when I'm on this medicine. And he would say, you have returned to baseline. And for me, this chasm is dramatic. Okay, this chasm, there is absolutely no common ground on which my doctor and I are standing with some vision of where we're trying to get with treatment. My doctor is treating a disease. He's not treating me, a person. And he considers the fact that he had been able to stabilize me and maintain me without recidivism in the community as an outstanding outcome. For me, it was a treatment failure. Something dramatic had to begin to change in order for me to be able to regain my life and to move on and achieve the things I wanted to do in my life. A radical change needed to happen in how my doctor and I worked together. And I've devoted my life's work to trying to understand how those of us with diagnoses of major mental disorders can find common ground so that this kind of profound loss of years and human potential does not occur. And I can tell you without a doubt that this treatment gap that I'm showing you here occurs routinely in psychiatric care. This is not at all unusual, where the prescriber sees as their job the treatment and stabilization of a medical condition at the expense of an individual's quality of life. Or I would even say life, period. So my work has been about finding a way to create common ground between us so that we can agree on where we're trying to get to. So over the last few years, I've developed a web application that's been created by and for people in recovery from mental health disorders. And we're creating this web application for folks with psychiatric disorders. We consider ourselves disruptive innovators. We know that to bring the voice of the individual to the center of the care team is going to disrupt practice as usual. And although it's the right thing to do, it's not always the welcome thing. And so it always feels, we've been using that Sisyphus image, it feels like very much an uphill battle at times to make this happen. Common Ground is more than a concept. This web application, we currently have centers up and running in the areas that you see in green, and we also have Common Ground centers that are beginning to go online in the white boxes with the green trim. So we're more than a prototype. We are being used in the real world. And our work focuses on the sickest of the sick and the poorest of the poor. What we focus on are folks who are diagnosed with what gets called severe and persistent mental illness, people who are usually have multiple comorbidities, people for whom, many of whom are homeless or are receiving government checks. About 70% of the population of folks are unemployed and living on government checks, if they even get those. These are folks living on the streets in board and care homes, residential programs, etc., all accessing services within the United States in the public sector mental health clinic. My feeling is if I can make collaborative-centered, person-centered care happen in that environment, I can do it anywhere. And I should say we can do it because you guys have been just heroes to me and just really inspirational. You know, I've been spying in on these meetings for a long time now and just really learning a lot from you all. Currently, we are in assertive community treatment teams, and these are mobile treatment teams that go out and engage people who are high-end users of services and engage them in treatment. And mental health centers, subacute inpatient units, substance abuse treatment centers, and peer centers are some of the types of programs that are using the Common Ground web application. And what we've learned in an overview is we have over 11,000 users as of January of this year, and 58% had shared decisions across all sites entered for over 31,000 Common Ground health reports that people create, and that we think that shared decision-making can happen within the constraints of the 15-minute psychopharmacology appointment. Will Torrey here at Dartmouth has identified 30 tasks that a psychiatrist or nurse practitioner needs to perform within that 15-minute consultation. It's a lot to do. So to add that one more thing is really hard, and I can tell you a bit about how we did it. My vision is this: if I walk into a typical mental health center, what I see are a lot of torn, outdated, and really boring magazines with a lot of really sedentary people sitting there for varying lengths of times, twiddling their thumbs, stepping out for a smoke, and pretty much deactivated, just blobs on the chairs. And then I look over here and I see hurried, harried, desperately busy workers. And I say to myself, what's wrong with this picture? And I know many of us have brought up this point today, that there's this extraordinary human resource, those of us who in the patient role, who can be activated and empowered to participate more. So the way I look at it is, in today's healthcare environment, there is no more time for waiting in waiting rooms. Waiting is over. That we must, in order to save our lives, prepare to participate in our own self-care and to recover our lives after a diagnosis of a mental disorder. That's the task that's in front of us. So how can we begin to make this happen? Generally speaking, what we've done is we have converted the waiting area into a decision support center staffed by people in recovery from mental disorders. We have an emerging workforce within behavioral health. Medicaid not long ago passed a waiver for states that allows states to pay for peer staff to work in the mental health workforce. So here is an emerging workforce. Peer staff, Medicaid reimbursable peer staff are in about 34 states right now, I believe. And so that's a good emerging workforce looking for a unique job to do. This is a unique job. Peers in recovery, paid salary workers, there to greet you as you come into not the waiting room, the decision support center, offering you kindness, a cup of tea and a chat, but also inviting you to get on the computer, the web-enabled computer. And we say to folks here, it's just like the microwave at home. You can just touch right here, and off people go. So that's before the psychiatric consultation. Now, what's the key to making this work is that we work closely with reception staff to frame the new method that the medical clinic is using, the psychiatric clinic is using. An appointment is for the individual 45 minutes long. You come in a half hour prior to seeing the doctor because you need to prepare to participate. And then you see your doctor, and then if you'd like, you can return back to the decision support center to finish up your work there. And so we've inserted it very much into the care pathway and also the individual's pathway as they're moving from coming into the clinic. They go to registration, they go to the decision support center, they see the doc. So from the patient's point of view, this is a 45-minute visit. Billing-wise, it's two separate visits, to the DSC, the decision support center, and to the doctor. So people, while they're in the decision support center, prepare a health report for their doc, and the health report has some unique features that I'm going to explain in a moment. And then during the appointment, folks review the health report with the doctor. And the doctor, of course, because this is a web-based application, can view the health report through their own sort of lens or their own page. And increasingly, with our mobile treatment teams, people are doing this work out in the field with folks. They're not even coming into waiting areas or anything. They're actually doing these on Android tablets out in the field with a homeless person under a bridge who's going to see the psychiatrist. It's interesting stuff. Common Ground has 4 fundamentals, I think, that are, we call it the secret sauce. It's the secret sauce. So these 4 fundamentals, for me, capture the 4 things that those of us who are healthcare service users must do in order to recover our lives after a diagnosis of major mental disorder. The first thing we have to do is we need to snap out of the hypnotic trance of taking pills is going to recover me. That's what they say on the TV commercials, and it's what pharma tells us, but it's not the truth. Pills can be an important part of recovery, but it's only one tool among many tools that the vast majority of us will have to use in order to reclaim our lives after this diagnosis. So one of the first things that we help people do when they come into a decision support center is to identify what we call their personal medicines. Personal medicines are the things that we do that put a smile on my face and that make my life worth living. Personal medicine and pill medicine often work together to create a pathway into the life I want for myself. So the first message people get as they go through a very structured process of defining their personal medicine with fidelity, we have fidelity measures for these, is they learn what they're already doing and what they can do to help themselves. The second fundamental cornerstone of Common Ground is creating a power statement. All users of the software create a personal power statement. A power statement is how I advocate for myself so that treatment supports my recovery. And I'll give you some examples in a moment. The third cornerstone of the Common Ground approach is decision support. When you have a diagnosis, you want to know what it is, you want to know what others have done, and you want to know what your treatment options are. And then finally, the shared decision-making component involves working with my professionals to make the best choices for my recovery. So, personal medicine, how I help myself. It's what we do, it's not what we take. I can't tell you how new an idea this is to many, many, many people diagnosed with mental disorders, that I can actually do something. We say to people, look, exercise can change your biochemistry. Laughter can change your biochemistry. If you tell me tobacco changes your biochemistry, we say, yeah, but it's not what you take, it's what you do. You know, it's what we do. It's not some over-the-counter concoction of NyQuil and whatever you put in it, right? That's not personal medicine. Personal medicine is what you do. We did an analysis through the Dartmouth Psychiatric Research Center of 2,500 examples of personal medicine and found just fabulous examples from folks. Pretty much everyone using the software is able to define their personal medicine. Now this is important because it's not just a futile exercise, but this information is going to our doctors as well, as you'll see in a moment. This is really important information for my doctor to know. Here's another example of how we build up an individual's personal medicine. We have what we call personal medicine cards, and these are just small index-sized cards with suggestions about how to improve on your personal medicine. In this case, how to do a better job managing voices and how to customize that for yourself personally. The second thing we do is these power statements. So anybody using the software creates a power statement. A power statement connects the doctor's medication treatment plan with my personal goals for my recovery. In other words, doctors are really good at focusing on illnesses and management of symptoms, and in particular, symptom abatement, symptom reduction. But in particular, sometimes if you get the wrong kind of meds or too much meds, it makes it impossible to pursue the other things that are important in your life. A power statement connects the doctor not to symptom reduction as the treatment goal, but to what matters in my life, where I want treatment to take me. Here's a power statement from an actual Common Ground user. The most important thing in my life is working at Pizza Hut, and I want medication to help me feel less depressed, so I can work at Pizza Hut. And I want you, doctor, to work with me to stay out of depression so I can continue to work at Pizza Hut. For this measurement-oriented group, what's the only acceptable outcome of care in this scenario? If this guy's not working at Pizza Hut, treatment has failed. So if we have medicated this guy into a total state of somnolence, we may have eliminated his auditory hallucinations, but he can't work at Pizza Hut. It's a treatment failure. People, we've got a systematic way of creating these power statements. We tell people power statements do three things. They introduce me as a person, not a patient. They say how I want treatment to help me. And they invite my doctor to collaborate with me in meeting my treatment goals. Power statements. Here's another example. I want to feel better and improve my mental health. I want to work together with you to find a medicine that will help me sleep better and ignore voices so I can drive my car and take care of my dogs. That's the indicator that matters. That's the outcome that matters. The third component of what happens in Common Ground is there's a recovery library. All of the content in our recovery library are written by and for people in recovery from mental disorders. So we totally respect the health-wise materials, patient education materials that teach us the biomedical information. But people need more than biomedical information to get well. So I may read a medication consumer fact sheet and realize that this medicine causes sexual side effects. But then, how does one weigh the pros and cons of staying on the meds and getting relief from depression and still manage a marriage with sexual side effects? That's what we call the lived experience. And patient experts, those of us living in recovery, we've got some good ideas about how to manage that stuff. So rather than throwing people out on the World Wide Web in sort of wide open patient-to-patient networks, we use an expert-patient approach to create a lot of multimedia content. And I can just give you some examples. People can watch videos of real people who've recovered their lives after a diagnosis of mental illness. So you can watch Sherry, and she's going to talk to you about, she went to her church, and they told her all she had to do was pray more to overcome her schizophrenia, and how she managed that. That's a real issue. Another real issue, when in the course of a dating relationship do you, disclose your status as a person with a psychiatric diagnosis, given the kind of stigma that's out there? Those are the real, we call it lived experience videos, first-person accounts. You can also do some data mining of your own data and track trends in your recovery. Of course, your doctors can see this as well. We have video walkthroughs on important things like when to talk to the doctor in situations of polypharmacy. So you can prepare during your time to talk to your doctors about these sorts of things. And again, we just try to keep it really real. Here's an antipsychotic decision aid that meets IPDAS standards that Laurie Curtis and the government, SAMHSA, developed, and we make that available to our folks. We make a strong focus in our recovery library on whole health. Those of us diagnosed with major mental disorders are dying on average 25 years younger than other non-diagnosed Americans. So the health disparity is enormous. The level of comorbidity is incredibly disturbing. There are massive efforts underway to begin to change this, but the bottom line is, we need to take a much more holistic approach, and we try to reflect that in our work. The final element of what we do is provide people with an opportunity to talk to their doctor about the things that matter in that condensed 15-minute appointment. Everybody gets anxious before you talk to the doctor. But imagine having a psychiatric disorder on top of that, an anxiety disorder on top of that. We view Common Ground as assistive technology that helps folks with psychiatric disability organize their thinking in order to prepare to tell the doctor in a one-page health report a very concise story about how I've been since my last appointment. Here's some examples of screenshots. We start with this simple screen, do you want to read or listen? And of course people can choose either. Most choose to want to listen. We do the how I'm doing scale and have you been taking your medicine, but we also say have you been using your personal medicine as well? That's an important indicator. And then by the end of the program, it generates some content that you might be interested in based on your response. And in this case, the person was indicating trouble with concentration, so the program might generate a personal medicine card to you that you might want to use as part of your self-care. And this is increasingly important because what we see in behavioral health is a trend of what are called med clinic-only clients. That the only care many people are getting is that once a month or once every 3 months in that med clinic. There is no therapy, there is no case management. I mean, the states are being devastated in terms of budget cuts in the areas of behavioral health. And so this stuff becomes even more important. Here's what our health report, the one-page health report, looks like for our docs. And of course, the individual can see their health report. We have a principle of full transparency in Common Ground. Anything the individual can see, the staff can see, as long as they're on your treatment team. But I wanted to show you what the doc's interface for shared decision-making looks like. After reviewing the report, the doc clicks the shared decision tab at the top. And we have tethered the power statement to the doc's shared decision. So this power statement was, swimming is very important to me to release stress. My medicine makes me gain weight and I'm embarrassed to wear a bathing suit. You need to work with me to find a medicine that will ease my symptoms and not make me gain weight. So that's the person's power statement, right? Now the shared decision, in order to meet the goals in my power statement, ... and then the doc enters the shared decision using my prescriber and I agree. I will work with peer staff at the DSC to explore more information about which medicine causes most weight gain and which causes less weight. We will discuss my options at my next appointment. And then doc has InfoRx and could, prescribe. In addition to our shared decision, you might also want to learn how to manage false beliefs or learn which antidepressants cause side effects. And then they can request support in following through with the shared decision. In this case, a support request would go to the Decision Support Center staff so that they would know, oh, we've got to close the loop here. We've got to do the follow-up. The doc and the individual are requesting help so that this person can look at their options about which meds cause less weight gain. Here's an example of shared decision. Between now and my next appointment, I'll try the antidepressant. I will keep a mood calendar, and I'll also note severity of sexual side effects, if any. I'll also go for a walk and push my daughter in her stroller. Exercise is also an antidepressant and will help me sleep. So what we see is docs using this are able to do more holistic care because they are right at their fingertips, have these other resources to recommend to people as well. I just wanted to show you real quick, if Common Ground is an amplifier, what are people saying through that amplification? And we've had some stunning findings. So here's an example of some of the questions that are asked. We have 11 questions that are common concerns about prescribed medicine, and we've got over 11,000 users. What are the top concerns? What are people saying they're concerned about? Because the field often assumes that those of us with major mental disorders don't take medicine as prescribed because we lack insight into the fact that we're ill, or that we're, genetically non-compliant or something. There's just this attitude, oh, mental patients, they just don't take their medicine. Just take your meds. Well, we use Common Ground as an amplifier and here's what people are saying. When asked, is the mental health medicine helping you all across time? And I think the length is 2007 through December 31, 2011. So that's a period of time across all clinics, across all users. The number one concern, 31% of people using Common Ground say the meds you're prescribing me, doctor, are not helping me. They're unhelpful. That's amazing. Since my last appointment, I've been concerned about side effects from my mental health medication. Yes or no? 21% of people say they're concerned about the side effects of their medications. Across all sites, all users. And so number one for all sites, all users is the meds are unhelpful. 31%. 21% are saying the side effects are bad. And finally, I'm concerned about how the mental health medicine is affecting my physical health. And the number there is 20%. These are the top three concerns, no matter what clinic we look at, no matter what treatment setting is going on. These are the top 3 concerns across all users for all time. And I think that that trend is amazing, and it's just so stable now over so many years. So what are we as professionals going to do about that becomes a really important question. When asked what concern are you mostly concerned about, people say it's the weight gain, 23%. So I'm just going to close with this slide. This is a slide from the clinical antipsychotic trials, which is a very large national study here in the United States that it was not funded by the pharmaceutical companies. It's funded by NIMH, and they were looking at the relative efficacy and effectiveness of antipsychotic meds, which you see listed across the bottom: olanzapine, quetiapine, risperidone, perfenazine, and ziprasidone. And the study found, to everyone's amazement, that despite all the advertising, antipsychotic medications are pretty much the same in terms of their effectiveness. Okay? But look at the difference in terms of a weight gain profile connected to each drug. Some drugs have much higher potential for weight gain, others have much lower. Some have much higher implications for development of cardiometabolic syndrome, where others have much lower. And so, in my opinion, we are working hard to migrate shared decision-making into behavioral health because it is the poster child for preference-based care. Equivalent outcomes across these various types of treatment, but profoundly different risk-benefit ratios for these meds.